Welcome to Care Beyond Barriers. I'm Christina Farr, and today, along with my panel, Dr. Tom Kelly, Dr. Hannah Allen, and Dr. Simon Koss, we are unpacking loss of trust and shared direction. Trust seems to be eroding on all levels, from patients towards clinicians and the healthcare system, and from clinicians towards leadership. So how do we rebuild trust and create a shared direction? Tom. This is a hugely important topic, loss of trust. So I'm going to kick us off by talking about COVID, the pandemic.
Okay.
Maybe take us back to the years when we were a lot of us were at home and you were practicing.
Yeah.
What was it like for you at that time to start to see just how serious medical misinformation had become?
Yes, it was an interesting time because I was starting to found Oscar, which became Heidi, and
Wait, it was a man and then it became a woman?
yeah, it's a long story. So Oski,
We like that.
Yeah, upgrade. So Oski is a clinical exam. So it was a education product originally back in the day. But yes, I was in the ICU, like at the coalface of where in Melbourne they were expecting this, impending kind of doom of very unwell patients. But in Melbourne they really locked down cases. So we really tried to suppress caseloads almost entirely until there was a vaccination or some therapies or something. And I remember because I was the one doctor in my family, I was just seeing like so many varying opinions, like people in my family are tradies and they do physical work and they couldn't work and they.
What is a tradie?
Tradie, like a contractor.
Oh.
Yeah. So like doing stuff with your hands, like in the physical world. So they were sort of stuck, not able to work, and then the irony was when the vaccines became available, that was like it's like divided the crowd. Half were keen, half weren't. They kind of like didn't want to do it, but they knew that if they did it, they'd be freed. So that's why they said yes to it. I think what I realized was that there's no implicit trust, that like patients won't automatically trust the medical fraternity just because we're the smartest and bestest of us in the ivory tower. It needs to be basically like a free flow of information and like just as much as you can, like being fully straightforward with the truth. We learn in medical school respiratory viruses are basically uncontrollable. Like everyone is going to get it. Like I knew straight away, like everyone is going to get it. The question is like, what's the profile of how fast everyone gets it? But they were just fear-mongering because they wanted to control the social norms, and they want to say like everyone should be wearing cloth masks. Like you could wear a cloth mask, not wear a cloth mask. The difference would be like marginal, if anything, especially with something as virulent as COVID. So I think there were a few mistakes, especially in the public health messaging, that eroded trust, so that when we did actually want to, talk about great things that we had created, like these new vaccines, we'd sort of lost the trust of a lot of people. And I do think it's had a lasting impact, which I'm sure we can talk about.
Yeah. So I was in the US at the time, and we had a lot of misinformation coming from people that didn't even have medical degrees. It was really just kind of armchair experts, self-proclaimed experts that had a lot of opinions that they disseminated on social media that became very successful and very popular at this time. We also had a group of public health physicians who absolutely stepped up. People like Dr. Bob Wachter, who's at UCSF, and he just went to Twitter for the first time in his career in a very big way. And for millions of people became this voice of reason. And it wasn't just that he was sharing the medical research. It was also that he would humanize and contextualize it. He would say, at this point in time, my wife is considering going out to a restaurant. Here is what I told my wife. And I think it was really so valuable for so many people. And yet in medicine, that there isn't really that culture of public communication and being open on social media and having this public voice. And many of these people also got a lot of pushback and hate and all sorts of negativity. And some of it was from the public, but some of it was from their own peers. You saw this kind of, why you mentality with some of the physicians that really stepped up. And my view on it as somebody at the time who was reporting on COVID as a journalist at the time was how do we possibly counteract all of this bad information without good information. How do you view now the role of the physician as needing to be far more public than ever before? And then how do you get comfortable saying, okay, yes, this time it is me. I have that expertise and I am going to start talking about the things that I know.
In the UK, there was so much sort of heavily politicized change going on. And it was very much kind of knee-jerk changes one day to the next, 1 month to the next. You know, there was no plan that anyone could follow. So I was working as a GP in the hot hub. So I was the front line wearing scrubs, you know, we had no proper masks. So we were just wearing surgical masks and going on home visits to really sick patients. And every day we would come in and meet and they would regale out, you know, in West London, we've got this many hospitals, we've got this many ITU beds, we've got this many ventilators. And every day it was working towards D-Day, which was like 6 weeks' time when we'd run out of ventilators. So it was a really unique experience, actually. And my experience of it was that although it was chaos in that we had no like North Star of where we were going or real sort of plan, because it kept evolving, I feel like patients did really trust us, actually, in those moments. Patients were coming in who were really sick, and patients who didn't need to come in understood when we said, we're not going to spend time writing your sick notes, or, you know, we're going to be really focusing on the really critical stuff, which was actually quite refreshing.
The pandemic was a very different time because the whole concept of medicine is it's highly personal and very contextual, which means that you go to a medical practitioner and they're not going to download the sum total of what's in their mind and that becomes your health literacy. They're going to contextually look at what's going on with your specific things and give you enough information to understand what's going on and the treatment rationale so that you can get on board. Then during the pandemic, that was flipped on its head because the whole of society needed mass education immediately, and we're not really geared up for that. The expectation is the people will come one by one and the education happens one by one out on a societal basis. So I think we needed to do things. Here in Australia, we had press conferences and the chief medical officer would stand up. We had weeklies from the health departments and they would talk about the state, and it was a very different state of public disclosure. It's not natural, but I think during this period we lent into it. The other point about trust was there was a time where we really didn't know. So coronaviruses are common. We know about respiratory viruses, but specifically with COVID-19, we couldn't give you a prognosis of what does a long-term implication look like. And then things were trickling out into the media like spike proteins, and you would hear about these scientific concepts without the contextual background. So I think in that we recognise that the influencer channels, especially when people weren't going out and socialising in their normal crowd sources, were still hungry for information and getting it from various sources. I think from a public health perspective, we can probably take some of those things going forward and think about how we do public health messaging better at scale about things that affect everyone, and that's probably important in rebuilding that trust.
I think there's comfort with press releases and mediums like that, less comfort amongst a lot of the physicians I know with things like TikTok, which feel very bleeding edge. And yet that's where many patients do spend hours of time every single day. And the physicians that I have seen embracing these mediums, I find it fascinating because I have a friend who's a urologist and she's got a big TikTok platform, and she will take all the latest research in the field, and she's just, you can imagine it, you know, she's pointing to the research and her videos, and then she'll talk to you in a really human way and explain what it all means. And what I love about it is it doesn't feel like she's talking down to anybody when she does this. She's sharing important research to people that care about these things. She's talking about menopause, she's talking about women's health. She's also really taking the science into account when she communicates, and just to see that explode to hundreds of thousands of people tuning in, it just seems like a platform that if we want to rebuild trust, we have to start meeting patients where they are.
I was thinking of like the history of medicine. You know, it was a self-assessed body of people that had special knowledge that no one else had. And then we kind of created our own set of guidelines and principles and selected people who could become doctors. And like literally, it's like being a doctor is about having some special set of knowledge that no one else has. And so I think there's a certain brand of doctor that treats that superiority as like their value. Like, you're paying for my opinion, you're paying for my knowledge, my abilities, my experience. And so I remember, like, I went to both my internship and in my studies, like I would say that was the brand of medicine we got taught, that like this is a, you know, very special club, and you have a very special place in society, and you have to be very careful about what impact you have on the medical profession. So we are kind of scared off from being too public, I think, generally, because...
And then it's also, you've got, you know, people above you who've got more training, more hours. And shouldn't it be them and not you?
The hierarchy of it all.
Exactly.
Yeah.
Exactly. And it's like, I'm just trying to get onto surgical training.
Yeah.
But I do think in the Hippocratic Oath, like, there's something about like doing the right thing for patients is not just the patient in front of you, but also for society, and, you know, using your free speech and talking about what you think that the best evidence shows, and still upholding like your medical standards and critical evaluation of evidence and all these other things. So there were some really good examples where doctors were doing that. I think where I saw interesting conflicts was where the evidence didn't map with the public health story that the governments wanted to tell. And then there was some interesting conflicts where it's like, maybe the evidence isn't quite as strong, or like, you know, is it really dangerous for kids to be in schools? Like, is the evidence that they're going to have significantly worse outcomes than just having any other coronavirus or flu? And usually the reason is because it's hard to have a nuanced conversation. Like, maybe the answer is no, the kids could go to school and they'd be fine, but then they would become vectors that would give everyone the virus. And so for that reason, they should stay at home. But that kind of like complex logic, I guess some public health decision makers were like, we can't endow everyone with that information, so we'll just say that everyone has to stay home and it's dangerous for everyone, because it's just easier to understand, like COVID bad, rather than maybe it affects different people differently.
You talked about being paid for a medical service, and the way doctors are paid, at least, is to treat patients one at a time with maximal confidentiality. And when we talk about free speech, it is free. So I get out there and I'm doing this awareness, but why are we doing that? Maybe there's something to it with the incentives in the system. If we're not doing a great job of public health promotion and awareness, how are we aligning the incentives to make sure that happens well?
I used to have headaches in pregnancy, and I got some uniform advice, basically, like, don't take this medication that I was using for my headaches beyond a certain point. And at one point in time, we kind of dug into that, and she's like, actually, you know, I told you that to make it easy for you, but you probably could have gone to this number of weeks at this level and titrated. And I said, well, why didn't you just say that? And she said, well, it's just, we only have 5 minutes, and it's just easier for me in that 5 minutes to come up with something that is really simple, that I know you'll understand and you won't make a mistake. And that got me thinking, well, if we're giving doctors all this time back, then rather than like go to the lowest common denominator of giving them the least information possible that keeps everybody safe, could we move to a new style of communication, which I think actually would build trust a lot more, where the doctor could say, this is my plan for you, here is why I'm making this plan for you, here is why I'm not doing these things, and like a little bit more of just kind of the background of what got them to that decision. And I think that takes us away from a really long history of very paternalistic styles of communication in medicine, that we forget sometimes that it wasn't even that long ago that we didn't tell patients that they had cancer. Because we thought it would be in their best interest not to tell them. And there are still countries around the world that we don't tell them that they have Alzheimer's, right? So we're not that far off from that.
I feel like patient outcomes improve when they feel more listened to. And I think that we absolutely are moving away from that kind of paternalistic, you know, I'm a doctor, so I'm going to tell you what to do because I know best, to this kind of shared care model. But I think that also technology plays a role in supporting the self-care of patients. And in your example, I would love to see also the ability for the patient to then critique the plan. asynchronously.
The most exciting use case for evidence is to actually provide references for the plan.
Yeah.
So it's like, not, because sometimes you think it's just a figment of the doctor's imagination. Like, why is this my plan? Like, is this just what they're saying? Like, should I get a second opinion? So you could actually almost like retrospectively reference the doctor's thinking. Now, maybe if they're off track, that's an issue. And yeah, I think that's the way to restore trust. You just share the information. You stop acting like a doctor from the 50s. And,
Yeah. In GP training, we get taught a kind of communication technique called I, so ideas, concerns, expectations. And it's honestly, it unlocks so much. It can be a bit frustrating sometimes. What do you think might be going on? And sometimes they'll have weird and wacky ideas, and sometimes it's actually really valid points that you would have missed had you not asked it. But equally with their concerns, right? Had I not asked about your headache, what are you really worried about, Christina, right? You might be like, I'm actually really worried I've got a brain tumour because I read about somebody in the Daily Mail yesterday, not that you'd read the Daily Mail, and they had a brain tumour and they presented with headaches, right? And if I don't ask it, you're probably not going to come out and say that. So I think it's really important to ask those targeted questions to actually feel heard, and it really builds that kind of trust.
I think there's a time and a place for decisive paternalism. So if I come in a multi-trauma from a road vehicle accident, I want my doctor to be decisive and not explain things to me and jump on and do the right thing. But I think what we're talking about is a society that is becoming more health literate and dealing with conditions that they don't just take a pill and they're episodic and they're fixed. They need to actually internalise what's going on so that they can self-manage appropriately, and that's more of a coaching conversation. Yeah. I do think there's a role for AI to help parse the different information so that it's consumable to the right people at the right time. And that's part of the problem with medical knowledge and content. It's so highly technical, and even if you could understand what it's saying, it actually needs a foundation base to interpret it. Yeah. Well, if you can have an ever-patient agent explain that to you in grade 8 reading level, maybe explain it to you using analogies of hoses and pipes and cans and the rest of things. Now you can actually up-level that health literacy. Maybe it's just for that condition, but for those specific instances, it could make a huge difference to the burden of disease in our society.
So I want to touch on something a bit controversial, and that's misdiagnosis. Just around this room, quick show of hands, who here has been impacted by a misdiagnosis or a missed diagnosis, either you personally or somebody close to you?
Yeah.
Absolutely.
Yeah.
So that's all of us, and I think what we're experiencing really bears out at a societal level. Most people or a loved one have experienced something like this, where they've gone to see a doctor, the doctor doesn't know what's going on, they feel dismissed. Oh, it's anxiety, oh, it's in your head, oh, just come back in 6 months. And something was wrong. And I think for many patients, that is where that lack of trust comes from. So we could say, AI is going to solve this. And we've seen incredible cases online that have made the waves in media of just amazing, rare diagnoses that, a parent of a sick child has gone to 14 doctors and nobody's been able to diagnose it. And then suddenly it's ChatGPT that comes up with the right answer. But I think there's also a way, again, back to this communications issue. In so many of these cases, the patient feels gaslit. The patient doesn't feel empathized with, does not feel heard. And that's where resentment starts to build. So you've got these AI tools potentially, working for you or against you as a physician, getting us closer to the answer. You've got patients who've had so many of these experiences. How do we then rebuild trust in light of all that?
So what I expect to happen will be, it's just the combination of doctor and an AI system. Like, you just won't expect to see anyone without something like Heidi in the room. Like, I've personally had experiences where with loved ones, like, doctors are just missing obvious questions, like slam dunk, like to the point where I am saying like, hey, you should ask this question because I know they have this symptom and that will change what you're about to do. And it's not because I'm better, it's just because I'm acting as a second party to the conversation and I'm not as tired. So I'm not missing the bit of the diagnostic sieve that they're not remembering. And it's just a simple like cognitive bias. Like doctors are fallible. Sometimes we forget about whole organs, systems. We forget about different conditions or tests we can order. And so it doesn't take much as a nudge to just be like quite a lot better, I would say. And the amazing thing about the doctors, I think that is very hard for something like Heidi to ever do, is to manage risk. So, and also manage like the health economics of like, when do you order a test, or when do you actually intervene? Or, if I've got a month ahead, can I get them to come back before I get them to go get the MRI? And I think that doctor AI hybrid, it's like the opposite of what society expects, where if a doctor's using an AI, how can I trust them? It's like actually the other way around. If a doctor's using an AI, you can trust them because they have the system supporting their decisions. So it's not where we are today. Like today we do documentation, but I do think that's where we go in the next few years.
We often talk, don't we, about that kind of middle of the night fear where you wake up in a cold sweat and you go, oh, did I remember to do that thing for that patient?
Yeah, I forgot to ask if they had pain in their back, or whatever.
Yeah, whatever it is, And I love the idea of having tools and support that are managing that, the patient outside of my immediate kind of interaction with them, to better support them, but also to better support me, so I'm not waking up in the middle of the night in a cold sweat. But I think it sort of building on your point earlier around the kind of coaching, I think it's going to be around really supporting patients at home in their own environment and being an extension of a clinician, but in a familiar way to them that they trust, who understands their ideas, concerns and expectations, and is able to kind of build it in a way that suits them in an environment that they want it in.
We've had that landmark publication in the US, To Err is Human, and now I think it's a matter of public discussion that in fact medical error, there are significant rates of medical error. It's the third biggest killer in the US. So that's the baseline, and just simple statistics says 50% of doctors are below average. How do you take that natural human fallibility, but also the brilliance and the empathy and the accountability and the creativity, and then marry it with the hard science that computing can bring to the table, that horsepower of being able to sift through tomes and tomes of medical literature, analyse many data points in real time, look at cohorts across in ways that humans can't. If we can bring that human and that artificial intelligence together, then kind of like the Swiss cheese model, we make sure that the holes don't align, and hopefully you trap some of those errors.
And there's also like a time constraint I always think about. Like as soon as you book an appointment, I know you're going to see me, let's say in a week. Heidi could just contemplate the case for a week, I just like start reading papers, ignoring the cost of doing the computation. Eventually that will become very low. So then imagine, like let's say I see Hannah or I see Simon, and I know Hannah uses Heidi because she loves Heidi, and Heidi's thinking about me for a week before the appointment, contemplating everything that could be going on. Or I see Simon, who doesn't believe in Heidi and just doesn't use it at all. Like as a patient, who am I going to choose to see?
So who are you going to feel more listened to?
Exactly, yeah. And then I had the opportunity to add other problems or maybe explain like other things, like if we have time, can we cover this as well? And maybe Heidi just like gave the advice, So I think this like hybrid will just become expected.
100 years ago, there were so many diseases that we didn't even have names for. And so all those patients probably got told that there was nothing wrong with them and that they were crazy and sent home.
Yep.
And do you think that's true today, that there are just gobs of patients out there that really do have something going on, and we just don't even know what it is yet because we haven't named it?
Yeah, all the idiopathic stuff,
Yeah.
The idiot stuff.
Yeah.
Yeah. It's just usually we don't know why it's being caused or what's causing the pain.
Totally. Like it has to evolve. It 100% will be the case, right? Like we can't be arrogant to say no, we know everything. We absolutely.
I feel like there are like the gut brain stuff. Like
absolutely.
That stuff is like so real, and yet it seems like we've just, and all the hormonal stuff.
Absolutely.
But the flip side is, you got to keep in mind, medically at least, the principles of beneficence and non-maleficence. You've got to first do no harm before you actually look to do good. And both my parents are doctors, and they've told me a story about the guy who came in with pruritus ani for investigation. He had an itchy bum, and they investigated him, and as a result of the investigations that he had, he ended up dying. And a bit of judicious application of your judgment there, you'd think, is this something that we should be doing this investigation for, and what are the diminishing returns? I'm still chewing over what you said about that temporal dimension. If we've got 8 minutes with a patient and now we're returning a few more minutes, so you've got 2 extra minutes, what if I could, a week ahead of time, have my condition thought about, and then not just the 8 minutes with the primary care doctor, but afterwards proper follow-up. Now, instead of having a high risk, got to be on my game and got to get everything out and all the rest of it, you can actually treat in a larger window. And you can do it using a technology that doesn't have a marginal cost of labour and doesn't...
I mean, imagine saying to somebody, you have cancer. If somebody said that to me, I would just zone out the next 8 minutes of them talking to me.
Yeah.
And then a week after I would have emotionally processed that news, then I would have 5,000 questions.
Yeah.
But I wouldn't have any opportunity to see the oncologist.
And what happens today is you're told that, and then you're told a whole load of other stuff, and then you leave and you go, I can't remember what they said.
Yeah.
That's exactly what happens today.
And then there are questions, I think, so many complicated issues related to not just treatment options, but then how that relates to quality of life. Like in America, we're still doing knee replacement surgeries on people that are effectively in hospice. Because nobody is sitting down with the patient and explaining, are you somebody that needs this surgery? What will the surgery do for you? And it's the same thing in so many other areas. But again, it's just that lack of time where it's almost like we created a factory system where we just push patients to the most efficient and sometimes highest cost thing without sitting down to talk to them and saying, what do you want?
Well, and also with rising patient anxiety or patient expectations, the clinician often mirrors that. So their anxiety and their, sort of want to over-investigate increases.
You get sort of transference of the feelings. Yeah, my other experience with this was I had a loved one who got unwell. And I remember going into the hospital and I had this, because it was a general surgical thing, so I had an ingoing sort of perspective of what I thought it could be. And then I remember I used one of the deep research models to be like, this is what I think's going on, give me some feedback. And it was just incredible. It found these studies that for this exact population of someone, presenting in this age group with these symptoms, this is what the pretest probabilities were. Here's what investigation you should order. And I was in surgery, and this was just way better than me. I checked the study, it wasn't hallucinating, it was a real thing. And so then I imagine, if I was a surgical registrar deciding between 3 patients, who gets the scan first, who goes to the operating room first, it'd just be irresponsible for me to not use this, because that thing could have found a study in a minute that would have made me make a much better decision. So I feel like the anecdotal will line up with reality. It just takes a bit of time to execute the product, make it feel good, make sure it's safe.
Okay, but you're talking about something that requires having not a massive ego.
Yeah.
And let's be honest, physicians, a lot of physicians.
They don't have to tell anyone they're using it. Yeah.
Did you show the clinicians that data?
No, actually, that's the scary part. I let them do their thing.
Yeah.
And then afterwards, the way they managed it, I wasn't according to evidence, but it is what it is. You just have to accept what you've been given. Yeah. I did advocate. I was like, why are we doing this? You know? And then try to defraud their thinking a bit. But it is what it is.
But I'd be interested to your ego point of how that would be taken on board, right?
Yeah, I remember another time I was having a fight with someone about a drain, and I used the evidence. I was like, there's no evidence for this. Why are you doing it? And it's sorry, my patient. So there, it is a cultural thing, maybe. And
if they're not going to hear it from you, are they going to hear it from some piece of software?
Yeah, exactly. Or a patient who's non-medical and not you can give them the weapons, but they can't arm themselves. I think it'll change. I think because the systems will help patients advocate for themselves, the doctors will just have to get used to it. Well, they just probably won't have that many patients, is what I expect.
I think that advocacy is really important, because you were playing the part not only of the advocate when you're speaking up, but the navigator to a loved one going through that journey. And I think about all the times that I've been a navigator to someone else who's trying to make sense of this complex, convoluted health system, where to go first, when to go, all of those questions. If that capability could be taken out and put onto a buddy who can help you, at least with the first pass of rationalising a very complicated system, that would really help people get to the right venue of care in a timely manner.
Yeah, I agree.
So one of the big issues I think that we face today is that when a patient has to go all the way to the doctor's office, which is a huge pain usually, and they don't want to be there, they want to walk out with something. They want to walk out with a script. They want to walk out with some feeling of validation that they just messed up half their day for a reason. But sometimes they don't actually need anything. You know, it's a viral infection that will clear up on its own. It's a good example. And a lot of the time, the physician just ends up giving them the script anyway and saying, well, we'll give it to you just in case, because nobody wants to leave that encounter feeling completely unsatisfied. So how do you think AI plays a role with this, where the answer is do nothing? And I would imagine that is the answer in a lot of cases.
There was a retired GP who recently said, I want to impart some knowledge before I retire. And the one key message that I've realised throughout my career is one large part of the role that we play as a GP is to help people understand that we can't really do anything, right? And to support them through that journey. In my experience, a lot of the time when people are coming in, the research shows that even if you give people a piece of paper, like saying do these exercises, they feel more validated and they feel like their expectations have been met through that consultation. But I think it's about feeling listened to again, right? And if you can communicate effectively, which is incredibly hard in 8 minutes, like why they shouldn't have that script or why you don't think it, complies with Centaur criteria. So they don't need, penicillin, for example. I think that is incredibly challenging.
Okay, let's do a quick role play.
Yeah.
So imagine I'm a patient and I say I've got a really bad cough and I've had this cough for a month.
Yeah.
And you get to the point as a physician where you don't think I need penicillin and probably what I have is a virus.
Yeah.
Give it another 2 weeks, it clears up.
Yeah.
How do you communicate to me so that I don't feel like I just wasted my time for nothing?
Yeah. But I think it's about the empathy. So I think it's understanding that you have come in, you have taken the time to come and see me. I appreciate that. But this is, what the research and the evidence is showing. Some patients will be interested in the research and the evidence and some will just be like, I still want the antibiotics. You can always give them a delayed script, right? Like that's always an option. What the research has shown is that a tired doctor is more likely, who's burdened down with other things, with admin, for example, is more likely to give you that script off the bat without even really digging into anything. That's where things like using Heidi can really support. By reducing that cognitive burden, the doctor feels less fatigued by the end of the day, therefore is more likely to actually practice at the kind of optimal sort of skill set.
And I would argue it's the fact that I just messed up half my day, sat in your waiting room and came to see you. If we had a asynchronous consultation that took 5 minutes by text message, I don't think I would feel, maybe I just sort of ticked the box and said to my husband, oh, I did go and see that doctor. You told me to go see the doctor said I was fine. And I think there's some relationship here with how much we burden patients unnecessarily and how much they have this expectation of wanting something out of the encounter. Yeah,
it's like meeting them where they want to be met, right? Exactly. Like in their environment.
The other thing is like the healthcare system and incentives. So this is like where a privatized system versus a public system is very different. Because if you work for the NHS, you can sort of do the effective right thing for the UK. Because you can say, well, I don't want to do this, so I'm just going to dig my heels in and say like, no, you're not getting antibiotics. Like if you're in the Netherlands, you have to basically have pneumonia to get antibiotics. And it's because they take antibiotic resistant like militantly. They don't want everyone on vancomycin in the hospitals because that causes other problems. And that like you can do that because it's a publicly funded system. But if you have choice and you say, well, I don't want to see you anymore, Dr. Tom, then what am I going to do? It's like, well, I still want you as a patient. So now it's this weird, like, I'm now offering a product as well as a service, and obviously I'm kind of conflicted because I want to do the right thing by you, and I know it's probably bad for you to have these antibiotics, or for the society, but I don't really care about that because I just want you to keep coming to my practice. So I do think some of the health system incentives that we create is also tricky. I don't know how you incentivize a primary care doctor in the US about antibiotic resistance. Maybe their prescribing habits somehow could be like a measure they get measured on.
I think it's going to be really tough. But, you know, the other thing that's changing that we haven't really talked about is the fact that most patients in the US and many other countries couldn't even tell you the name of their primary care doctor.
Exactly,
and
yeah.
part of it is they don't see any primary care doctors, and part of it is they will just see the next available provider. They don't care. There is no continuity. It's whomever I can see most efficiently. Yeah. So part of it is probably creating standards that we try to get doctors to practice around. And then part of it is also, let's just, you know, patients clearly want efficiency. They want efficiency. That's why they don't have a primary care doctor. So there may be ways in which we lean into those efficiencies.
Yeah.
Because it is in those efficiencies that I think patients will start to see healthcare as far less burdensome. Yeah. And, you know, I think a lot of patients think, oh, I'm being dragged in, not because it's what's best for me, but because of the economic model
it's the only way
of
I
the
can
hospital, where it's just more advantageous financially for me to be brought in, or I'm being brought in for something that could easily have been done at home, and they're doing it because it's just more insurance.
So that's the way they get paid.
Yeah, it's a higher claim. It's how they get paid. And so that, I think, is where the trust is really eroding.
Yeah, and I think moving towards that kind of community-based model, right? Like meeting people in their communities, utilising other things like pharmacies, for example. We're doing a really good job at like prescribing for UTIs and upper respiratory tract infections, etc., managing that within communities and pharmacies rather than everything having to come back to the clinician in the clinic.
Great. Well, we unpacked so much here today. And I think we're moving into a future where definitely we have the potential to create a lot more trust.
I think so.
But the only way there is going to be through really that kind of patient education, that accountability that we talked about, that ability to say, you know, I was wrong, and really just more FaceTime between patients and physicians when we need it, and then no FaceTime when we don't need it. So thank you all for joining me today.
Thank you.
Thanks, guys.
Thank you for tuning in to Care Beyond Barriers. We'll see you next time.